All right, everyone. Thanks a lot for joining us to the ECE Distinguished Speaker Series. Today, we are very honored to invite Dr. Nuria Oliver be with us. Nuria is a co-founder and vice president of the European Laboratory for Learning and Intelligence Systems. She is also the co-founder of the Valencian ECE units, devoted to research on human and humanity-centric artificial intelligence. She is the chief data scientist at the DataPub Alliance and the chief scientific advisor at Wonderful Institute. In March 2020, she was named commissioner for the president of the Valencian region on AI strategy and data science to fight COVID-19. And since then, she has led a team of more than 20 data scientists. She also led Valencian A4 COVID team, which has recently won the 500K XPRIZE Pandemic Response Challenge. Nuria actually received a lot of awards, and I don't want it to name it, but she is the fellow for IEEE, ACM, and also European Association for Artificial Intelligence. So today she's going to introduce her work on data science against the COVID-19. So Nuria, all yours. Thank you.
Thank you. Thank you so much. Hi, it's really a great pleasure to be here, even if it's only digitally. And yeah, for the next, I guess, 45 minutes or so, I'm going to share with you the work that we have been doing since March of 2020 on using data and machine learning to help the government in the Valencian region in Spain make better decisions regarding COVID-19. This initiative came to be as a result of me realizing in March of 2020, at the beginning of the pandemic, that a pandemic was imminent and we weren't going to leverage and take advantage of all the research results and all the work that had been done for the past decade or decade and a half on using data and machine learning methods in the context of infectious diseases. I had worked in 2008 with my team at Telefonica on the H1N1 flu outbreak in Mexico. And then I had worked with my team at Vodafone on the Ebola outbreak that took place in DRC. And at the time, in March of 2020, I was actually working with my former colleagues from Vodafone on a project of modeling the spread of malaria in Mozambique. So I had this realization that, we were going to miss the opportunity of using data to have more informed decisions. So I reached out to the Spanish government and I reached out to the Valencian government with the idea of creating a team of scientists from the universities and the research labs working together to support them in their decision making. And the Valencian government was very keen on this idea, and very quickly they said yes. So they named me commissioner to the president on AI and data science against COVID-19, which is sort of like an honorary position. And since then, I've been leading a team of volunteer scientists working on this. This is a picture of the Valencian region of Spain. It's on the east coast of Spain, on the Mediterranean. And this is a list of the different institutions and the people that have been working with me on what I'm going to explain to you today. Basically, our challenge has been how to bridge this gap, the gap that there is between where the data is and where the policymakers are. Ideally, we would like their policies and their decisions to be based on evidence. And if data is a digital representation of an underlying reality, we would like their decisions to be based on the analysis of the data. But this is not the way traditionally political decisions and public policies have been made. So our challenge was how to bridge this gap. And to do that, we divided our work into 4 different work streams. So our first line of work was human mobility modeling, because an infectious disease like SARS-CoV-2 or coronavirus disease that is transmitted from human to human, it doesn't become a pandemic if people don't move. So that's why we have been confined for so many months, and that's why understanding and modeling human mobility is so important. The second line of work has been on building computational epidemiological models. So models that would enable us to predict the pandemic curve evolution, not only under the current conditions, but also under different possible scenarios of interventions and non-pharmaceutical interventions and sort of like measures. The third line of work has focused on building predictive models of intensive care occupancy, hospital occupancy, and also inferring the prevalence of the disease. And this is very important, particularly in regions where there are no tests. So you don't really know how many people are really infected with the virus. And last but not least, we had an entire line of work on a citizen science project called the COVID-19 Impact Survey, which is a really large survey, one of the largest in the world so far. It has almost 700,000 answers from different countries. And it's an incredible tool to listen to people, to really understand what is the situation and what's the perception of people during the pandemic. Even with all this work, which sort of like brings us a step closer to the policymakers, there is still a gap because the output of all these modules is still pretty technical. So I think one of the elements that has been key for the success of our team is this layer here of results interpretation and prioritization and aggregation. And this layer has been fundamentally done by me in collaboration with a director general working for the president, so an actual politician that is a member of our team and that has come to every single meeting and that has really done a lot of the exercise of translating our work into actionable insights and sort of like political language. And this is very, very important for the work to actually have impact. In terms of the technical skills, everyone is a scientist at different levels, from students to full professors. Everyone has a background in statistics or math or computer science, engineering, physics. And then depending on the area, there are some sort of like areas of expertise. So the mobile analysis team has a lot of background on data wrangling and data visualization and sort of like spatiotemporal series analysis. The epidemiological team is very strong in data modeling, computer modeling, and machine learning. The predictive models team has a lot of background in machine learning as well. And the citizen science team also has background on statistics and human-computer interaction. We've been working really hard. I schedule daily meetings for many, many months in the morning. And then for many, many, many months, I've been writing reports every day with the predictions of the day, with insights about important topics for the president to know about, with feedback on, I don't know whether schools should be open or not, or what's the role of contact tracing, or what's the role of digital contact tracing, and things like that. We have a very active Slack channel that we use all the time, and we share our code using GitHub. And of course, everyone signed confidentiality and sort of like a code of ethics to work on this project. This is an example of a picture of one of our daily meetings. I had never worked with any of these people before in my life, and but we saw each other every day digitally, and we only met in June of this year, so a few months ago. We have a website, but it's in English. This is the official website of the government of Valencia. So our team has gotten a certain amount of international visibility. And I think one of the reasons is because it's actually not easy to create such a team. And a group of scientists from many different institutions, including myself, we wrote this paper for Science Advances back in April of 2020, where we reflected on the role that particularly mobile data could play in the context of the pandemic. And we also discussed, some of the challenges. So the challenges include a lack of a digital mindset and a lack of capacity in a lot of the public administrations and governments. There are a lot of difficulties in terms of accessing the data. Of course, there are concerns about privacy and the security and data protection, but everything that I'm going to describe today has been done using non-personal aggregated data. So there is a lot of valuable work that can be done using non-personal data. There is also a gap between where research is and where the real world is. And of course, we want to have impact in the real world. So how to bridge that gap is not necessarily easy. And then, of course, in the context of a pandemic, when you need to make decisions, all the time, if you don't have all these elements in place, it's obviously impossible to leverage, the data to support, the decision making. And, because we managed to do all of this since March of 2020, maybe that's why, we appear in Politico and in MSNBC and in Wired, sort of describing our experience. So what have we done? So I'm just going to summarize a little bit of the work that we have been doing. So the mobile data analysis team, the impact of this work was fundamental during the first wave of COVID-19, because as you probably recall, Spain was the second worst country in the world in terms of the incidence of the first wave of COVID-19, after Italy, in the early days of the pandemic in March and April of 2020. So it was extremely, extremely stressful. And we had the most severe confinement probably in Europe, where we couldn't leave our house, for many, many weeks. So we were appointed by the Vice President of Spain, Calviño, the pilot region, to be able to analyze human mobility data that was shared with us from the National Office of Statistics, who in turn had accessed the data from the three largest telcos in Spain. So the three largest telcos in Spain shared the data with the National Office of Statistics. They combined the data. Evidently, everything was aggregated and anonymized, and they share with us mobility flows for the region of Valencia since March of 2020. So we were able to analyze that data and answer some interesting questions. For example, one of the questions that we answered was, what was the impact of the confinement on the radius of gyration of the population? The radius of gyration is the radius of a circumference that contains the movements, the daily movements of a population. And we observed that there was a reduction in the radius of gyration of 65% in the entire region, which was larger than the average for Spain, which was 54%. So this means that if before the pandemic, the radius of gyration was 10 kilometers, during the confinement, it went down to 3.5 kilometers. We also analyzed the impact of the stay at home campaign. There was a big campaign asking people to stay at home. We didn't have the data, of course, of the home exactly, but this data that we had access to had these regions that you see here on the map, which was the smallest granularity that we had access to. Those regions were defined as follows: for municipalities that were between that were up to 5,000 people, they merged the municipalities to have at least 5,000 people. So each of these areas has at least 5,000 people living in them. That's why some of them are very big. This means that there's a bunch of villages here probably that have a few people living in them. And then in the cities, you see the areas are much smaller because you reach 5,000 people much quicker. For municipalities that are between 5,000 and 70,000 people, there is only one area for the entire municipality. And then municipalities that are larger are split into different areas. And what we show here is the percentage of the population that did not leave their area of residence for more than 2 hours during the confinement period in Spain. And as you see, the map is mostly green. This means that there was at least 80% or or more of people that didn't leave their area of residence, namely 88% of the people in working days and 92% of the people on weekends didn't leave their area of residence because of the confinement that we had implemented, the government had implemented. This is a visualization of the evolution over time, where we can see that at the beginning of the pandemic in March of 2020, there is still yellow on the map, which represents a drop of around between 70% and 80%. Still a big drop, but eventually the map became all green when there was like severe confinement and there was no labor mobility. To be able to support public policy making, the geographic granularity that is meaningful to the government is what is called the Department of Health. A Department of Health is the geographic region that is served by one hospital. The Valencian region in Spain has 24 hospitals. It has 5 million people living in that. So this graph shows the percentage of people that didn't leave their area of residence per Department of Health. And we can see that in all the departments of health, it was over 80% of the population that didn't leave their area of residence. We also have information about labor mobility. So the mobility that is due to people commuting somewhere else. And what this map shows is the drop in labor mobility when comparing the labor mobility during the first wave of infections in Spain and baseline day in November of 2019, so before the pandemic. And on the map, the greener the map, the larger the drop in labor mobility. On average, there were 60% fewer people outside of their area of residence during working hours. But we can see that some areas had a huge drop, like this area here, which is around 90% of drop in labor mobility. And then some areas like these areas here that are sort of like pink, they had a much smaller drop in labor mobility. So this is very useful for the government to understand the level of compliance of the population with the mobility confinement measures. Because we have incoming flows and outgoing flows, we can also compute what we call the activity levels. And here is showing the drop in activity levels when compared to a day in November, where again, the greener, the larger the drop. Some areas had a huge drop, and then some other areas didn't have such a big drop. This is at the beginning of the pandemic. But then if we look at what happened when the government implemented a 2-week ban of all work except for essential services, there was a massive drop of activity levels everywhere. When we look at the different departments of health, these are the 24 departments of health. In yellow is showing the activity levels during the confinement for each department of health, and in orange, the activity levels before the pandemic. And as you can see, there is a huge drop in activity levels everywhere. We also, given that our customers, so to say, were the policymakers, the communication of the results and the visualization was very important. So we built this interface, which was accessible to anyone, so they could look at the different municipalities and look at the incoming mobility, the outgoing mobility, the activity levels, the stay-at-home campaign success, and they could select the range of dates that they were interested in and understand how the different confinement measures were impacting the population. Because we have incoming and outgoing flows, we could run a community detection algorithm and identify what we call mobility communities. These are geographic regions that are self-contained in terms of mobility. So they have a lot of mobility within the region, but they don't have a lot of mobility across regions. This information was very valuable because if the government was thinking of implementing partial confinements, they could understand the impact of a partial confinement depending on how much mobility there was in that region. We identified 14 different mobility communities, some of them very self-contained with like a 94% of self-containment in them. The second work stream has focused on building epidemiological models. And these models enable us to answer how many people would be infected under different scenarios, and also to understand whether the confinement measures were enough or not to contain the spread of the virus. We have built 3 different kinds of models. The first one is a traditional SAIR metapopulation compartmental model. In these kinds of models, you divide the entire population into 4 different states, which correspond to each of the letters of the SAIR acronym. Because the SARS-CoV-2 or COVID-19 was a new disease, we assume that everyone initially is susceptible to the disease. And then, so everyone is in the state S. And then with a certain probability, beta, people become exposed to the virus. Those that are exposed with a certain probability become infectious and infected with the virus. And then with a certain probability, they retire from the system because they recover or they die. This kind of system is given by a set of differential equations, and the parameters for COVID-19 were already estimated in the literature using data from China and some of the countries, the early countries where the pandemic started. So we fine-tuned those parameters for the Valencian region in Spain. And we also included mobility in the SAIR model, so we could build daily predictions on the number of cases in the region and in each of the provinces of the region using this model. We also built an agent-based model based on the Reina platform. An agent-based model is not meta-population, so it models each individual in the region. So we have 5 million agents, and each of the agents has an age, and it has a gender, and it has a contact matrix. And then underlying there is also a SAIR model that determines the state that each of these people is in. So they could be susceptible, exposed, infected, or infectious, or retire. And using this model, you can run simulations and see how the pandemic would evolve. We made predictions every day using this model on the number of hospitalizations, number of cases, number of active cases, number of intensive care units, and number of deaths. And finally, at the end of November of 2020, I received an email from the XPRIZE Foundation announcing the XPRIZE Pandemic Response Challenge. And as a teaser, more than anything, I shared the information with the team. And I told them, well, you know, maybe what do you think about this? You know, should we go for it? And a couple of researchers were really motivated, and they said, yes, we should go for it. I was sort of like acting a little bit like a devil's advocate because that was a huge challenge. The challenge entailed building a predictive model of the number of cases of COVID-19 in the entire planet, basically up to 6 months into the future, and taking into account all the different interventions that were implemented in each country and region in the world. So it was really a huge challenge, but the team said, yes, let's go for it. So we created a sub-team called the Valencia IA for COVID sub-team. And we went for the competition. And then, you know, to our surprise, because I never ever in my life thought that that was going to happen, we actually ended up being the winners of the competition. So that was really an amazing experience to the team. And I think it's the first time that a team from Spain wins an XPRIZE competition. So we were really happy. So for the XPRIZE, we use a deep learning based model based on sort of like a baseline model that the organizers of the XPRIZE were sort of like suggesting as a baseline. And is LSTM based, so it's using recurrent neural networks, and it has 2 different branches. The bottom branch, which you see here with an A, is a branch that models the interventions that are implemented in each country or region. We had 236 countries and regions in the world that we had to model. And the A is for action. So there were 12 different kinds of interventions that could be implemented in each country. And this sort of like models the interventions that are implemented. On the top, we have the models that are trying to model the pandemic, the evolution in the number of cases. And as you see, there is a bank of LSTMs, because what we did was we clustered the entire planet based on the dynamics of the number of cases into 9 different clusters. And then we built an LSTM for each of the clusters. And then on runtime, depending on which cluster each country or region belonged to, we use one LSTM or another, and then the output of the LSTMs that model the number of cases is influenced by the LSTMs that are modeling the interventions to provide the final prediction on the number of cases. Our performance was actually pretty good during the competition. So I think we were third on the mean rank globally and the first in all the European countries and all the Asian countries. But more importantly, we finished this model at the end of December of 2020. And Spain, and particularly the Valencian region in Spain, had its worst wave right after Christmas of 2020. So we were able to use this model in a moment that was extremely stressful to the government because we had a massive wave of infections. And our model actually worked really well. Here I show the ground truth on the number of infections in yellow, and in blue there is the predictions based on our model, and in red there is the predictions based on like a standard baseline model that was also using recurrent neural networks. And as you can see, we were pretty accurate on predicting the peak of the infection and also the number of cases on the peak. So we were able to help the government scale and understand how long the wave was going to last for. The second part and the final part of the XPRIZE competition entailed building this layer here, this pink layer, which was sort of like an artificial politician in a sense. We had to build a prescriptor of intervention policies. And there were 12 different kinds of interventions that we could choose from. So it's a 12-dimensional vector. And for every day and for every country and region in the world, we had to recommend which interventions to apply and with what level of intensity. So to do this, we basically had to find the set of solutions that were on the Pareto front on a 2-dimensional space, where on the one axis, we had the cost of implementing such policies, because of course, shutting down the schools or shutting down travel or not allowing gatherings has a social cost and an economic cost. And on the other axis, we had the number of cases that you would have if you were to apply such a policy. And the goal for this AI system was to identify automatically for each of these 236 countries and regions in the world, and for any moment in time, and for any period of time, the set of policies that would be on the Pareto front. That is the set of policies that will have the best trade-off between the cost and the number of cases, in such a way that for a certain cost, there wouldn't be any other policy that would lead to a smaller number of cases than the recommended policy. So we did that. And we also built a visualizer of the different policies. So you could click on the different countries and it will show you all the different policies. Each policy here has a different color, is a dot of a different color. And this will be the Pareto front. So the range goes between these two policies on the extreme. The blue policy, which will be the policy of I don't do anything. So the cost is 0, but the number of cases is like really, really high. And then the other extreme would be the policy where I do everything. So I take all the 12 possible kinds of interventions and I put them to the maximum. So the social and the economic cost is very high, but the number of cases is very low. So in between, there is like, for every day, there's roughly 7.8 million of different policies that you could choose from. And then we had to sort of identify the optimal ones. And here it shows you the levels of activation of each of the different kinds of interventions that you could use, and then the resulting number of cases depending on the policy. So this is the area on building computational epidemiological models. So the third area that we've been working on is building predictive models of the incidence of the disease, the deaths, the hospitalized, the intensive care units for each of the departments of health, but also for each of the departments of health, we build recurrent neural network-based LSTM-based models of intensive care occupancy and hospital occupancy, both in general and of COVID-19 patients. And last but not least, in March of 2020, we realized that there were a lot of important questions that we couldn't answer because we didn't have any data sources from. For example, what is the social contact behavior that people are having? What is the economic and labor impact of the pandemic? What's the resilience of the population? How much longer can people stand, all these confinement measures? What's the prevalence of symptoms? Are there enough tests? Are people getting tested? What's the emotional impact of the pandemic? What individual protection measures do people take? Is contact tracing working? I mean, there were so many questions that we couldn't really answer. So we decided to launch a survey to actually ask the people, the answers, to all these questions. So we launched the survey on March 28th, 2020, and the survey became viral. And in 40 hours, we collected 140,000 answers. And that was so impressive that we felt really grateful and emotional that people, were so willing to tell us, how they were doing. So we felt obliged to analyze the data really quickly and write the results really quickly. So we published a paper really fast where we published the results of the first week of data collection, and we published, the main conclusions of analyzing this data. We also built a couple of servers to visualize the data. This is the latest visualization in Tableau, and it's available. You can look at it here, elisalicante.org. Here you can see the URL. And so anyone could actually look at the results, and actually the media and of course the policymakers, but also citizens and the media have been regularly looking at the survey and reporting the results that they found the most interesting, based on the survey answers. We also have a few scientific publications based on the analysis of the survey. When we reached the first peak of infections in April of 2020, there was a very important question in everyone's minds, which was, have we reached herd immunity? Because we didn't have any tests at the time. No one really knew how many people had actually been infected with COVID-19. And of course, if we had reached herd immunity, there wouldn't be a second wave. So that was a very important question to answer. So we decided to try to answer it in April of 2020. And we did that using 3 different methods. The first one was using a generalized linear model based on the answers to the survey, and particularly based on the following answers: the presence of a member of the home infected, the presence of symptoms, which is one of the questions in the survey, and then the age and the sex. And using that, we were able to infer the prevalence of the disease in every region of Spain. And a couple of months later, the government published a seroprevalence study, and our estimations were actually quite aligned with the seroprevalence study. And the main conclusion was the average estimated prevalence of the disease in Spain was around 5%. And in the Valencian region of Spain, which is here, was between 1.6 and 3.4%. So very far from the 65% or 70% for herd immunity. The second method was using the data about deaths, and using both the absolute number of deaths and also the excess of deaths, we were able to estimate how many people would have to be infected to explain the observed number of deaths. And we obtained roughly 5% for Spain and between 1% and 3% for the Valencian region. And finally, using our SAIR metapopulation model, it has an underlying number of infected, which is the red line, but the blue line is a number of reported cases. And as you can see, there's a huge gap between how many infected people the model has underlying and how many reported cases there are. So using the number of infected individuals, we estimated that there will be a prevalence of 2.3% of the population. So our answer to the government was, we are very far away from herd immunity, and when you will lift the measures, there will be more waves. And that was a very important message, because At some point, the government was hoping to tell the population that the pandemic was over because the wave went down. And we were like, no, 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 you can't say that because there's definitely the prevalence of the disease is very, very low. We also analyze the impact of contact tracing because, of course, you can't do perfect contact tracing. So we wanted to know what's the minimum amount of contact tracing that you need to flatten the curve. And according to our agent-based model, even if we got 40 or 50% of the positive cases contact traced, we could actually flatten the curve a lot. However, this model assumes that everyone that is a positive case can self-isolate. And we knew from the survey that that was not the case, as I will explain later. And right now, what we have done is expanded our models to take into account vaccination. So we have both the agent-based model and the deep learning-based model that considers the vaccination in the different countries, and also the level of like vaccination in the countries. So we are building predictions using that. And to finish describing the work that we have done, I thought it could be interesting to you to know a little bit more about some of the answers to the survey, because I find that they're quite fascinating. So I wanted to share some of the insights coming from the answers to the survey. The first one would be about the emotional impact of the pandemic. And week after week, since April of 2020, we have been finding that the most impacted demographic group is the youth, the 18 to 29 years old, and particularly the women, which are shown here in red color, and the men are shown in blue color. So if we look at the people that report levels of stress or levels of anxiety that they consider are damaging to their health, we can see that there's a huge difference between the youth and other age groups. Even loneliness, which is usually associated with the elderly, the youth is the ones that are reporting the levels of loneliness that they consider that are damaging to their health because of the pandemic. When we look at the perception of the government measures, throughout the entire pandemic, the population has been demanding more measures. So the yellow line is the people that think that the government should do more, and the green line is the people that think that the measures are enough. And as you see, basically the entire pandemic, everyone thinks that the government should have done more. When we look at the individual protection measures adopted in Spain, we see a pattern, which is women are a lot more compliant than men. Women are the red bars, men are the blue bars. And as you see, the different protection measures, women are with much more probability, the women say that they do this measure than the men, except for having the contact tracing app installed, where there is more men that before that they have it. And as you can see in Spain, we have a very high willingness to get vaccinated. Spain is one of the countries that has the highest percentage of vaccinations in the world, and the willingness to get vaccinated is very, very high in the country. When we look at the evolution of the perception of risk of different activities since May of 2020 until now, September of 2021, we see that the activity that people consider the safest in terms of risk of getting COVID-19 is doing sports individually outdoors, which makes sense because I don't know how you could get COVID-19 doing the sports individually outdoors. And the activity that is considered the least safe for the entire pandemic is flying by plane, even though there hasn't really been a lot of like outbreaks in planes. But and this is also consistent with other countries who have data from other countries. And in every country, flying by plane is considered the least safe activity. Some activities seem to be seasonal. For example, going to the beach, which is the red line. During the first part of the pandemic in 2020, it reached its peak of people thinking that it was safe in the summer of 2020. Then it sort of became unpopular, and then it became again, people thought it was safe in the summer of 2021. So I think there is a high correlation between how safe people think different activities are and whether they do them or not. We also have information about the context of socialization. We ask people what is the the risk level of their main socialization environment. And we divided into no risk, which means I don't socialize outside of the home. Low risk, which means I socialize with masks and protection measures outdoors. High, medium risk, which is I socialize with protection measures, ventilation, social distancing, masks, but indoors. And then high risk, which is I socialize indoors with no protection measures. And we can see there is a pretty high correlation between the high risk and the waves. The black, you can see the waves, and it's a fair alignment between people socializing in high risk environments and having a wave of infections. We also have information about whether people can self-isolate or not. So the main COVID-19 control strategy adopted in most countries is called TTI, which means contact trace. So trace the people to know whom to test, to know whom to isolate. So a key pillar in the TTI strategy is actually isolation, isolating the positive cases so they don't infect other people. However, since the beginning of the pandemic, we know that roughly 50% of the people aged 59 and younger tell us that they cannot self-isolate if they had to. The main reason is because of sharing the home, but there are gender and age differences in terms of the reasons. The youth is the demographic group with the highest likelihood to tell us that they cannot self-isolate because of psychological reasons, because it's psychologically impossible for them, or because of fear of stigmatization. And then we also see an age difference and a gender difference in terms of having to take care of children, where it is women age 30 to 59, which is the main age when Spanish women have children, where 28% of the females, but only 12% of the men say that they had to take, they said that they couldn't self-isolate because they had to take care of children. So we do see that women carry a lot of the burden in childcare, and that was very much also evident, during the pandemic. And finally, we also have some data on how effective the contact tracing app was or is. And our finding is that it was not effective at all. So from our original pool of 130,000 answers, of which roughly 30% report having the app installed, so that's very high adoption. Only of those, roughly 8% tell us that they had a contact with a positive case. So at least 30% of these people should have gotten a notification. However, only 86% of these people told us that they discovered it because of the app. And then only 27 reported getting tested, and only 7 reported testing positive. So out of a pool of 130,000 people, the app helped identify 7 positive cases. So that's a really, really minor impact. So what have I learned after working for all these months, on this topic? So I think one of the main learnings is actually a very obvious learning, which is a pandemic is not just a public health challenge. It is a societal challenge, and we need a holistic approach to be able to effectively tackle it. I've also learned that there is a lot of room for improvement into creating a virtuous cycle between these 3 elements. On the one hand, data that is systematically captured and analyzed so we can actually understand where we are and why we are where we are and predict where we might be going. The second pillar is people empowered with the data and the technology. So we need to invest in the right amounts of people, social workers, healthcare workers, researchers, educators, and so forth. But they also need to be empowered with the right technology. And it doesn't help if you have contact tracers that are using some technology from the 1990s and it takes them half an hour to enter each case. This obviously doesn't scale. So we really need to invest in the right infrastructure and the right capabilities for them to actually be effective. And at the end of the day, we want to use all this data and analyze it and leverage the technology because we want to improve the policies, right? So I think it's very important to close the loop and to identify the weaknesses in the system and to tackle those weaknesses. For example, if we know that the youth is the demographic group that is the most emotionally affected by the pandemic, we probably should deploy programs to support the youth, emotionally and take care of their mental health. If we know that 50% of the people 59 and younger are unable to self-isolate, we probably should deploy some kind of infrastructure to enable people to effectively, self-isolate. We reflect about the intersection between data and technology and COVID-19 and this paper that I co-wrote for the Vodafone Institute in collaboration with Data Pop Alliance. And we talk about different recommendations that we think should be taken if we want to tackle, the next pandemic. I'm not going to go into the detail, but if you're interested, this is publicly available. And we do have a lot of publications where we describe, our work, in more detail. If you are not so interested sort of like in reading scientific papers, but we just want to read like a nice story, the Wire story that they wrote about us a few weeks ago is kind of like really nice. It's almost like a novel. It tells, how things work here. And just a couple of weeks ago, we got Best Paper Award at ECML. So, and in this paper, we describe all the details about the deep learning based models that we developed during the XPRIZE challenge. So I leave you with this. Thank you very much for your interest. And if you, if you would like to answer the survey is available. So feel free to answer. Thank you.
Thanks a lot, Nuria. Thanks a lot. This is a very inspiring, timely, and impactful research. The part I appreciate very much is it's not only about the data, about the technology, but shows the social impact and how important we actually bridge the research and the technologies and with our policy development and procedures and so on and so forth. That's very amazing.
Thank you.
So
I don't know if there is time for questions or if anyone has any questions.
Right. Any questions from audience?
I was curious how you thought that your experience with this situation might translate to other epidemics, maybe. I'm not sure what that would look like, but natural disasters, obesity, things like that. How far do you think that this could reach to other modern problems?
Yeah, so I think I have written a lot on the intersection between AI and social good and the 17 Sustainable Development Goals. So I think there is definitely a lot of opportunities. Me personally, I have worked on leveraging data to support, to help in the context of natural disasters. The mobile network data is very valuable because it enables us to understand if there have been displacements of the population because of the natural disaster. It enables us to understand how many people have been affected by a natural disaster, and it enables us to estimate if there are spontaneous settlements of people, so help can be sent. So there is not only us, but many other research groups that have worked on leveraging mobile network data in the context of natural disasters. I've also worked on financial inclusion in developing economies, and there are multiple intersections. So one is to use this sort of like large-scale aggregated data to automatically infer the socioeconomic status of a region. There are a lot of developing countries that have really obsolete censuses from maybe 40 years ago or 30 years ago, which is obviously useless right now. So being able to automatically infer the poverty levels in different regions in a country or different regions in the world is very valuable to be able to actually intervene and help, and prevent the regions from getting even worse. But I've also done work on financial inclusion. That was not done in terms of analyzing large-scale aggregated data, but at the individual level. So we built machine learning models for credit scoring for the unbanked. So there is roughly 1,700, 1.7 billion people in the world who don't have a bank account. And there is another hundreds of millions that are underbanked. And for all these people, getting access to credit is extremely difficult. However, we know that getting access to credit is a fundamental tool to enable people to prosper. You can ask for a loan, you use a loan to have some kind of like enterprise, to do some kind of endeavor and so forth. So at the same time, a lot of these people have a mobile phone. So the question was, could we use their behavior of using the mobile phone? They don't have a smartphone, but they have a feature phone. Could we use the patterns of usage of the feature phone as a proxy for financial sort of like stability or trustworthiness, so they could get access to credit in a much more advantageous way? So we did that, and we actually were able to show that was possible. And then that work actually inspired Mahindra Conviva, which is a really big Indian group of companies, to create a company called Yabex. And Yabex is actually doing financial inclusion in developing countries using leveraging mobile data. And I also worked on mobile money. So I don't know if you're familiar with M-Pesa. M-Pesa was sort of like a leader, sort of like, I guess, service in the world that enabled, again, people that are unbanked to be able to do financial transactions using the phone via SMS. So you could send money to someone else via SMS, or you could pay your gas bill, via SMS. And it's a project in Tanzania in understanding the drivers for mobile money adoption. So to sort of encourage and support financial inclusion. So I think there is a lot of learnings, and this is just work that I have done, but there is many others that have done work, on these topics. And so that was actually one of the reasons why I reached out, because I had worked on this topic since 2008. I knew what could be done, and I felt that we were going to be doing the same thing that we did during the flu pandemic in 1918. We were basically going to be using the same methods and the same tools for decision making. And I was like, we have to do something. I'm actually really sick at the time. I was in bed. I had a fever. I think I had like the H1N1 flu actually, or something like that. But I felt I had to help out. So I think the biggest challenge here is that the massive investments that need to happen to create this virtuous cycle, they need to happen. I mean, for us, we were the data science against COVID-19 team, and in March of 2020, data for the government was a PDF with a table in it. And we were like, well, this is not data. This is a PDF with a table in it. We need data. We need actually wherever you got this table from, wherever the source of this table is. So they don't have a digital mindset. They don't have a data-driven mindset. And that requires not only investments in the infrastructures and the technology, but massive investments in actually the workforce, in training and educating the civil servants, and hiring new profiles of people that are computer scientists, that are data scientists, that can actually help them leverage, the data that there is. And I think that's a big challenge. And hopefully it will happen, before the next big whatever it is happens, but it's still a way to go. For example, I mean, in the Valencian government, they are committed to creating a data science organization now, and I think that's going to be quite pioneering even in the world. But I think it has helped a lot to see the value through this project, and to see this completely different way of working, from the traditional way of like select policy making. But still, I think there is a long way until this becomes the sort of like state of the art anywhere. Yeah.
There's a message. Oh, Brady response. Yeah. Any other questions from audience? Nuria, actually, I have a question regarding about the use of the data. So at the beginning, when you joined the meetings, and I noticed you mentioned about the mobile data, the health data, and also the survey data. So I also say argument that the survey data is to epidemiological model development. So how can you comment on the necessary or the innovation of the survey data in traditionally we more on the technical side?
How do I, sorry, how
So
do I combine the
why,
survey
yeah,
data?
what is the importance of the survey data in developing like medical or technical scientific modeling?
So the survey data, I can show you the survey right now. So I think the survey data had, so we invested a fair amount of time in developing the shortest possible survey that would actually give us the highest amount of information. And some of the questions in the survey are medical questions. So here's the survey. So for example, the prevalence, the inference of the prevalence, which is based on the survey answers, we've done it because of the survey. So one of the questions in the survey is the symptoms. Symptoms here. And then based on the answers to the symptoms, we have this running model that is inferring the prevalence of the disease in all these different countries. So for example, look, this is the inference of the prevalence in Brazil. Look, Brazil now, it seems that the epidemic is over too. So I think there is a clear relationship there with the public health. We also have this other question on the collateral damage, where we and now things have improved a lot because this is only for the summer and now there is no collateral damage anymore. But if I show the data from a year ago, here what it shows is I can't make an appointment. And this is people that have cancer, diabetes, that are pregnant, and the numbers were really high. So the pandemic was having actually an important collateral damage on people who didn't have COVID-19, but needed medical care. And that was also very important for the government, to know. Then we have the answers about isolation. So as I said, the key mitigation strategy adopted by everyone is TTI. So the TTI assumes that you do I, so it means that you do isolate. And we know that people can't isolate. So the whole mitigation strategy fails if it turns out that you can't isolate. Why are you investing so much in tracing and testing if then people are going to go to work because they can't not go to work, or people are going to infect everyone in their family because, they can't be isolated. So I think there are, depending on the question, there is more direct or less direct impact. With the prescriptor of the interventions included the economic and the social cost, and some of the economic and social costs we can get from here. We have the economic impact of the pandemic, and because we have it over time, we can figure out sort of the economic impact of the different measures. And this is the economic, this here shows specifically the people that are actually saving more money, but these are the people that lost their savings, the people that lost their job. So I think there are different implications. Then we also have this question about vaccination that has been very helpful in terms of the public health, because we have the reasons why people don't want to get vaccinated. And in Spain, everyone wants to get vaccinated. This is like how many people are vaccinated in green. So as you see, in Spain, we have like 85% plus 1% plus 2%. So we have like 88% of the population that has gotten vaccinated. So it's very, very high. And then the different colors here tell you the reasons why people don't get vaccinated. So as you see, we don't have a lot of negationism. But if we look in Germany, look at the amount of people that don't want to get vaccinated. Everything that is not green is people that don't want to get vaccinated. So it's like a massive like negationist movement. And the blue, which is the most popular reason, is I don't trust my government. So there is like roughly almost like a quarter of the population, 24%, that say that they don't trust their government, and that's why they don't want to get vaccinated. So that's very valuable information, in terms of the policy making. So depending on the question of the survey, it could have a more sort of like analytical direct impact, like the symptoms question, we built a model out of that and we can infer the prevalence. And others the answers to the survey can be an input to the other models, or can be directly an input to the policymakers. So I think the survey has had sort of like its purpose in different ways. We also built a model, like in one of the papers that we just published in Nature, scientific reports, this one here. Oh, I don't have the picture here. Okay, so there is this paper here. The title is different because they didn't let us have this question mark in the question. But anyways, we analyze the people unwillingness to be confined and the factors that determine people unwillingness to be confined. And we also build a model that tries to predict the willingness to be confined. And that's, again, very valuable for policymakers, because they are making all these decisions on people's lives, with all these confinements. And I think it's important to understand if people are actually going to be willing to do these confinements, because otherwise you could have a revolution in your country, right? So, so I think there are a lot of interesting questions. For example, this other paper, we analyze the impact of the TTI strategy in Italy and in Spain based on the answers to the survey. So we are able to actually determine whether TTI works or not, based on the answers to the survey. Yeah. So I think the survey is very diverse, the kind of impact that it has had on our work.
Wow, very interesting. In fact, then this is definitely show the power of the data, and that we didn't fully discover, perhaps not yet. So it's so it's 1 o'clock, and I like to call one more time. Any questions from audience? Okay. All right. I guess, and this is the difficulty for the virtual format. But anyhow, Nuria, thank you so much for being with us and giving this seminars on this very important work. I hope this is continue, and I definitely believe this is going to benefit all of us in the future as well. So we will keep monitoring on this.
Thank you so much for the invitation. Sorry that I couldn't be there in person, but if anyone has any comment or questions later on, just feel free to email me. And yeah, have a wonderful weekend, everyone.
Good weekend. Thank you.
Ciao, ciao.
Thank you.
Yes, so we can have a recording. We will post the record to Pratt YouTube channel.
Thank you.
All right. Thank you, everyone.